Good afternoon, everyone. So in today's presentation, I would like to talk about some of the challenges hepatitis C patients residing in First Nation communities face when they are trying to access healthcare services. Saskatchewan has one of the highest rate of hepatitis C infection compared to the national rate, and infection rate in Indigenous population is 4 times higher than the non-Indigenous population. So the objective of our study was to identify challenges that hepatitis C patients currently residing in Big River First Nation community are facing, and also to identify some resources that are available within the community to support a mobile clinic that can be implemented to bring standardized hepatitis C treatment to patients in the community. So following a qualitative research design, we carried out one focus group with federally funded nurses employed through the community members, healthcare providers, elders, and administrators. We also carried out individual interviews with hepatitis C patients who are currently residing in the community. Transcribed focus group and interview data was analyzed using NVivo software package, and the results revealed that addiction and risky behavior, intravenous drug use, continue to put residents of Big River First Nation community at risk of contracting the infection. A combination of factors like lack of access to timely screening, diagnosis, and treatment, inability to navigate through the healthcare system. Most of them actually have to travel 80 to 100 kilometers in the nearest urban center to access treatment, where they face challenges such as confidentiality issues, there is racism going on, there is inadequate information sharing, so they really do not understand how to go about their treatment. And all these factors interfere with their ability to access screening and treatment. Further, socioeconomic determinants of health, such as poor housing, transportation issues, poverty, lack of childcare, also interfere with their ability to access treatment and stay adhered to treatment. At present, in Big River First Nation community, a variety of healthcare services are being provided through a health center, which is situated right in the community. And there are staff members who are employed by the community who are providing these services. Now, at the very core of the current healthcare delivery model are the nursing staff. They provide on-site screening and counseling for infectious disease. They provide addiction support. They monitor current healthcare issues that are present in the community. They also provide education support and implement directly observed therapy to ensure there is better adherence to treatment. Supporting them are elders and community members who provide additional mental health and addiction support. They also provide support groups for adult men and women in the community. Elders provide cultural and spiritual care through cultural ceremonies and traditional medicine. The next level is the administrative staff. They are the liaison between the nursing staff and chief and council. They support the delivery of the program through the healthcare center. They also advocate for funding and new programs to address the current healthcare problems that arise in the community. And at the very outer circle is the leadership, chief and council. They support the nursing staff. They promote the programs that are offered in the community. They also advocate for funding through Health Canada, provincial, and the federal government. Now, we identified several strengths in the current healthcare delivery model, which we thought is crucial for the implementation of the mobile clinic. The collaboration between the nursing staff, the community members, and chief and council can help support the mobile clinic which we intend to implement. Now, since the healthcare program or the hepatitis C treatment will be delivered in the community, access to care will be enhanced. And as the program will be culturally appropriate and it will be confidential, we're hoping that adherence to treatment will be high. There is also a considerable emphasis given to prevention, and that is carried out through the educational programs offered through schools and the support group for adult men and women. And there is also community engagement offered through community consultation. And we hope that this will help to promote the mobile clinic and also improve treatment uptake when it becomes available in the community. We also identified several existing communication channels like posters, radio station, and community consultation, and we intend to use these modes to promote the mobile clinic and to also spread information about hepatitis C treatment that will become available to the resident in upcoming months. In the past, nursing staff has used texting and cell phones to stay connected with their patients, and we intend to do that so that patients who are receiving hepatitis C treatment can stay connected with their healthcare provider, thereby ensuring that there is better adherence. The community has a Facebook page account, and we intend to use that to disseminate information about hepatitis C, what are the various ways of preventing it, and the treatment options that are currently available. And we would also like to use the Facebook page to disseminate information about the mobile clinic, upcoming clinic dates, and appointments with the infectious disease specialist. So in summary, residents of Big River are still at risk of contracting hepatitis C because of addiction and risky behavior, very consistent with what has been already shown in the literature. Residents also face a combination of systemic and socioeconomic barriers which interfere with their ability to access screening and treatment. Lack of cultural support and confidentiality issues can also interfere with whether individuals will access treatment and adhere to treatment. However, we are hopeful that standardized care for hepatitis C can be brought to the community through a mobile clinic, which can be supported by nursing staff who are already providing various healthcare programs in the community. So nursing staff can help provide timely screening and treatment uptake and also provide counseling and diagnosis. We also intend to implement directly observed therapies such that adherence to treatment is high. Support from community members and elders is very crucial to provide additional mental health and addiction support, and also promote education and cultural support, which is a very important piece when providing care in First Nation communities. Support from leadership and chief and council can help us identify additional funding to implement the mobile clinic and also consistently keep bringing the program or the hepatitis C treatment to the residents in their community, and to help create awareness and community engagement such that more individuals are interested in accessing hepatitis C screening and also treatment. In conclusion, I'd like to point out that access to timely screening, diagnosis, and treatment can be improved by delivering those services in the community and in collaboration with healthcare providers and community members. And in the end, I would like to acknowledge our funder, Saskatchewan Health Research Foundation, and the project was supported by Regina Kopal Health Region, University of Saskatchewan, and Big River First Nation community. I would also like to point out I have the health director, Ruby McAdam, from Big River First Nation community. So if you have any questions specifically related to the community, should be very glad to help you with that. Thank you very much.
Thank you very much.
Thank you very much for the important work. Wendy Wobesser from Kingston. I work in the prison environment, and sometimes it's a detriment to find out you have hepatitis C in that environment. Stigmatization, loss of social capital, that sort of thing. Do you think that that might play a role in a small community where confidentiality is hard to maintain?
Talking to the patient who are currently diagnosed with hepatitis C but are not in treatment right now, that was the most important thing that they brought up, was the confidentiality issues. Although they themselves know about that, a lot of them claimed that they haven't shared that information with their family members and or also with others with whom they might be sharing injection gadgets and stuff. So definitely confidentiality is one of the big factors. And the way we have been able to get past in Big River is a lot of the screening and the counseling is actually done by federally funded nurses who work out of the community, but they're not particularly in the community, so they're a bit removed. And because they have been working in the community for such a long time, they have a very good relationship with a lot of the community members, and they do value the confidentiality issue, and the patients feel more comfortable working with them as opposed to anyone else in the community.
Okay, thank you.
Yeah, thank you for your presentation. I'd like to know your reflections on circular migration of individuals from the community to more urban areas and then back, and the role of this in terms of HCV risk and acquisition.
Ruby, are you able to answer that? Yeah.
Hi, my name is Ruby Mamata. I'm Health Director at Big River First Nation. We find that our community is very small and everybody knows each other. So when someone leaves, we either know by word of mouth or by doctor. So when someone leaves, we know when they leave, and then we also know when they come back. First Nations community is very small. We call it the moccasin telegraph.
And if I could just, is there a sense of where the acquisition takes? Does the acquisition of HCV infection, does it happen in the community or outside the community when people leave to go to more urban areas? Is there any knowledge of that?
I think we've just starting to see the phenomenon. There is definitely a section of population who migrate in and out of the community. However, a lot of them still prefer to have their healthcare services accessed at the community because, again, of the confidentiality issue and also the support that they get, which is not available in the urban centers. But I think that is another thing that we would like to know. Is it at the community where they're at a greater risk? And we're trying to contain that, but then if they are getting the infection out of the community, that would be a bigger challenge to contain. But that's something that we will definitely follow in the following months.